Hello everyone. Let's now move on to module number 13. This is on developmentally supportive care. Again, another important aspect of essential newborn care, including issues like pain management, kangaroo mother care, environmental issues, etc. And to lead us in the discussions, we have a great team again. This time it's led by Professor Dr. Somsekhar Nimbalkar, one of the leading neonatologists of the country from Gujarat. And in his team, we also have Professor Dr. Dipen Patel and Professor Dr. Reshma Pujara, both of them again from Gujarat. Let me welcome all three of you for this module. Friends, let's watch the first two videos in this module and then start the discussions. Thank you.
Good afternoon, everyone. My name is Dr. Reshma Pujara. I am Assistant Professor of Neonatology at Pramukhswami Medical College, Karamsad, Gujarat. And today I am going to talk about kangaroo mother care, which is an extremely important and essential component of developmentally supportive care for the newborn babies. So in today's lecture, we are going to cover following components. We will talk about the definition of kangaroo mother care. We'll also look into the history of KMC. What are the various components of kangaroo mother care? The position of kangaroo mother care, various benefits which are evidence-based benefits of KMC, kangaroo mother care, the relationship of kangaroo mother care with cognition, and finding solutions for improving KMC. I'm sure as a nursing team, you all are aware and you must be practicing kangaroo mother care in your own respective units. So you can see this picture. It's such a beautiful picture showing kangaroo mother care given by mothers. And you can see the KMC is also given by father in this picture. In one of the picture, you can see twin babies are there where a mother is giving KMC to the twins. So what is a WHO definition of kangaroo mother care? So kangaroo mother care consists of following components. The first and the most important component is early and prolonged continuous skin-to-skin contact between mother and the baby. And that is the most essential component, skin-to-skin contact. Along with that, exclusive breastfeeding whenever possible, and early discharge with adequate follow-up and support once baby is discharged at home, and initiation of this practice in the facility, means in the hospital environment, and continuation of that at home. This is basically a holistic approach where we can cover every aspect. Now let's look at the history of KMC. So how did it started? So it was basically started by Dr. Edgar Ray Sanabria, and it actually began this method in 1978. What happened is that in one of the hospital in Bogota city of Colombia, there was a large burden of low birth weight babies, and along with that they were struggling with the resources, so they had a paucity of resources in the hospital. So what they did is that they started giving kangaroo mother care to the low birth weight preterm babies, and they have seen significant improvement in the survival of those babies as well as in the growth of those babies. And then subsequently the kangaroo mother care was introduced. So as you can see from this picture, and as the name suggests, what is kangaroo care? It is the care given by the kangaroo to their babies. So as you all aware that kangaroo has a pouch in front of the tummy, and a newborn kangaroo baby is actually cared into their pouch. And similar concept is applied to the newborn babies of human being, where a mother creates a pouch in front of her chest between the two breasts, and a preterm low birth weight baby is actually carried in that pouch till the baby is either full term or has a good weight. Now, what are the various components of kangaroo mother care? So, this picture describes all the components of kangaroo mother care. In the first picture, it shows you the position of kangaroo care. The second picture is about kangaroo nutrition, means breastfeeding, adequate breastfeeding during kangaroo mother care. The third picture shows early discharge from the hospital with continuation of kangaroo mother care. The fourth picture is about regular follow-up, where you can see a father is bringing the baby to the hospital for the follow-up, and he is already got baby in the kangaroo position. Then fifth picture describes the continuation of kangaroo mother care at home, and sixth picture is about the support given by the family members to a mother who is giving kangaroo mother care. And these are all essential components of kangaroo mother care. For successful KMC, all these components need to be fulfilled. Now let's talk about the position of kangaroo mother care. What is, in which position a mother should keep baby in skin to skin contact. So in this picture you can see a small preterm low birth weight baby is kept in front of the mother's chest, in between breast, in a upright position. So important is baby should be between mother's breast, number one. Number two, baby should be in the upright position, and mother need to support the baby's bottom, baby's body with both her hands. Baby is in the upright position with the frog leg position, and the head of the baby is turned to one side. Mother is looking at the baby, and there is usually a good eye-to-eye contact between the mother and baby. In this position, the baby is kept. Usually, the mother wears a gown which is open from the front side. Baby is also undressed, and only we can put a small kind of a piece of a cloth which is open from the front on the baby's body. So the skin of the mother and the skin of the baby is usually exposed, and they come in direct contact with each other. To keep the baby warm, we put the hat to cover the head. Baby can also be given socks to cover the legs and mittens to cover the hands. And usually baby is dressed with a small nappy. Once the baby is kept in this position, the mother and the baby both are covered with a warm cloth in the front so that baby does not get cold. So the idea is to give a direct skin to skin contact of mother skin with baby skin and providing warm environment. Now, once the baby is secured in this position, mother can either sit on a bed with a backrest, which is usually set at the 45-degree, or mother can also stand and give kangaroo mother care. Sometimes it is also given in the lying down position, although it is safe to given KMC while mother is in the comfortable position sitting upright with the backrest at 45-degree. There are special chairs available called KMC chairs, where they are actually a slanting chair where mother can sit on it with the appropriate rest at the back and give kangaroo mother care. Now let's have a look at various benefits of KMC. So as I mentioned, the kangaroo mother care has got loads and loads of benefits, and they are all evidence-based. The first and the foremost benefit is it promotes breastfeeding, because baby is all the time in close contact with the mother, and that stimulates mother's milk production. Plus, it is easy for baby to access the breast and take direct breastfeeding. It also helps with the temperature control of the baby. If we give kangaroo mother care to the small preterm low birth weight babies, those babies can be discharged home early because they have very good growth. The weight, head circumference and the height of the babies are improved faster when we give kangaroo mother care to the baby from birth. It also reduces the pain in the newborn baby, improves the attachment between mother and the baby. Sometimes it is a very, very good neonatal transport. So rather than transporting a sick preterm baby in a transport incubator from one place to another place, or even discharging this baby, we can use kangaroo mother care position as a mode of neonatal transport, and there is an evidence which suggests that it works better. It also reduces the episodes of apnea in premature and small babies, decreases the risk of infection, and there are loads and loads of evidence which suggest that it is very important for the long-term neurodevelopment of the preterm low birth weight babies. So let's have a look at these benefits one by one with their evidence. So as you can see, here is a mother who is giving direct breastfeeding to the newborn baby while baby was in the kangaroo mother care position. As I said, because baby is in close contact with the mother all the time, it increases the milk production. There is a significant hormonal influence, and baby has access to the breast so easily that baby will take direct breastfeeding very well, and it promotes long-term breastfeeding. The second advantage is KMC provides effective thermal control with the reduced risk of hypothermia. So in this study, as you can see, the cross suggests skin-to-skin contact at birth and continuous skin-to-skin contact. The circle suggests skin-to-skin contact and transfer to the warmer, and the triangle suggests the warmer is given from the beginning. Now, when they have compared these three modalities, they have seen that skin-to-skin contact from the birth and the continuous skin-to-skin contact has significant effect in maintaining the normothermia in the newborn baby, in the preterm low birth weight babies. So you can see from this graph, the temperature of the babies who are given kangaroo mother care and skin-to-skin contact continuously, it is well maintained after birth. The other advantage, as we said, the growth of such babies are much better than the babies who are not given kangaroo mother care. So KMC improves growth of low birth weight babies. There was a study done in 2008 where they have compared 206 neonates with birth weight less than 200 gram. They were randomized into two groups. The one group was given kangaroo mother care and the other control group was not given kangaroo mother care. Now the KMC babies had a better average weight gain per day, and the weekly increments in the head circumference and the length were higher in the KMC group. So it suggests that the significant higher number of babies in the CMC group, they suffered from hypothermia, hypoglycemia and sepsis. So clearly suggests that KMC has lots of advantages, especially on the growth of the preterm low birth weight babies. Then with regards to the neonatal mortality and morbidity, KMC has a significant effect on the neonatal mortality and morbidity. It reduces both these problems. So from the meta-analysis of 3 randomized controlled trials commencing kangaroo mother care in the first week of life have shown significant reduction in the neonatal mortality as well as neonatal morbidities in the form of severe pneumonia, sepsis, jaundice, and other severe illness in the newborn babies, especially those babies who are less than 2 kg. Now, it is also very effective in decreasing the pain response in preterm neonates. So, there was a study done in 2003 which suggests that pain score across the first 90 seconds from the heel lancing procedure were significantly lower than by 2 points in the kangaroo care condition. So if we are doing any procedure which are painful for the baby, and if we do that procedure while baby is continuously given kangaroo mother care, the baby will feel less pain and they will be more comfortable, especially in the preterm babies more than 32 weeks. There are studies which also suggest that same effect is seen in the extreme premature baby as well. So this paper, it suggests the kangaroo mother care in reducing the pain in preterm neonates on heel prick. So what they are saying that KMC, which was given even for a short duration of only 15 minutes before the painful procedure and then continued during the heel prick, has pain reducing benefits. And preterm neonate who are more than 32 weeks gestational age can benefit from a short duration of KMC to decrease the pain from the heel prick procedure. The other advantages, as I mentioned, that it increases significant attachment between the mother and the baby. So in a 16-month period, 110 neonates were randomized to KMC group and CMC group, and the duration of hospital stay was significantly shorter in the KMC group compared to the control group. And the total attachment score in the KMC group was significantly higher than that obtained in the control group. So what happens when mother gives KMC to the baby? They are actually more involved with their baby. They take good care of their newborn baby. They spend more time with their baby. And they actually enjoy the quality time spent with their babies, and that is how the attachment between the baby and mother improves. And that leads to the decreased postpartum depression in mother as well. So KMC will reduce the maternal depression. So it has benefit to the baby and it has benefit to the mother as well. Then, as I was mentioning, like it can be used as a transport incubator. So in these pictures, you can see the kangaroo transport was used while transferring baby from one place to another place. And it can be considered as a very safe, effective, and inexpensive method of the transport, promoting the parent and infant bonding. Now, those babies who are given kangaroo mother care in the NICU setting or KMC setting, they usually have a dramatic drop in the frequency of clinically evident episodes of obstructive apnea and or bronchoaspiration. But when the baby is in the kangaroo position, it actually regularizes the baby's breathing pattern, reduces apnea episodes, and periodic respiration are more frequent in the conventional care. So when the baby is in the kangaroo mother care position, their breathing is very smooth, comfortable, and it improves their saturation. Other thing is that the kangaroo infants, the babies who are given kangaroo mother care, they have a significant reduced risk of infection. So infections rate are less in those babies. There was this study where 431 low birth weight and premature infants were assigned randomly to the KMC or the traditional care, and KMC infants had higher intelligence quotient than those given traditional care. So it has a role in the neurodevelopmental outcome of the premature and low birth weight babies, especially more premature babies like 30 to 32 weeks of gestation. The difference was more significant. Those who required intensive care and those who had a diagnosis of doubtful or abnormal neurological development at 6 months. So, combining all the benefits together, if we review this, that there is a Cochrane database, a systemic review done in 2016, which suggests that KMC reduces morbidity and mortality in the low birth weight infants. It reduces mortality by 30 to 40%, reduces nosocomial infection by 65%, severe infection by 50%, hypothermia by 72%. It improves the weight, length, and head circumference of the baby, and it also promotes exclusive breastfeeding up to 3 months. And evidence for the mortality effect in the following subgroup is more like if the mother is been giving continuous KMC and if the KMC has been started within the first 10 days after birth. Now at this point I would like to mention, so which are the babies who can be given kangaroo mother care? So any premature baby, any low birth weight baby who is hemodynamically stable can be initiated kangaroo mother care as early as possible after birth. And in a healthy term baby or healthy low birth weight babies, we can start immediately after birth. First skin to skin contact immediately after birth is very, very useful and beneficial. And how long we can continue kangaroo mother care? So as long as mother and baby both are comfortable, KMC can be continued. But usually for a preterm and low birth weight babies, we try to continue at least till the baby is 2.5 kilogram of weight. After that, if mother is comfortable, if the baby is comfortable, they can continue KMC for longer duration. There is no harm in that. And once we put the baby, there are two types of KMC basically. One is a continuous KMC and second is intermittent KMC. Continuous KMC means a baby is given kangaroo mother care continuously throughout 24 hours and mother is only taking very short breaks for her daily routine activities. Although this can be very difficult, but it is possible. If a mother is giving kangaroo mother care at least for more than 12 to 13 hours daily, then it is called continuous KMC. And intermittent KMC means if mother is giving a kangaroo mother care for, say, for example, 1.5 to 2 hours in one sitting, and then she is doing 2 to 3 such sittings, then it is called intermittent KMC. Again, they are divided into short duration, medium duration, and long duration. But one important aspect is that once we initiate the kangaroo mother care, it should be continued at least for minimum 60 minutes uninterrupted, ideally 90 minutes, including the time taken for the putting the baby in KMC position and then removing the baby from the position, so that baby will complete one full cycle of the sleep in that position, and that is very important for the brain growth of the baby. We'll look into that in the next few slides. So, in nutshell, kangaroo position is the preferred routine place for the care beginning at birth and taking into consideration the physiological and behavioral state of the infant and parent. It is possible that KMC may contribute to the infant's stabilization. A removal from this place of care should be for a specific reason only, and kangaroo mother care should be used for the transfer of the infant to the neonatal unit after birth when appropriate, within the hospital and between the hospitals. Most medical and nursing procedures can be performed with the infant in kangaroo position day and night. even those babies who have been delivered by cesarean section, we can give kangaroo mother care, or we can give skin to skin contact immediately after birth. We can put the baby on a mother's chest immediately in the operating room. And afterwards, if mother is assisted with the transportation to the NICU for as much as KMC as possible without unjustified restrictions. If mother is not well, we can use father as a substitute for kangaroo mother care provider. And those babies who are on CPAP or on a ventilator can also continue to receive KMC if there is enough expertise available in the hospital. If the doctors and nurses who are looking after such babies, if they are expert in giving kangaroo mother care to the babies who are either ventilated or CPAP, then it should be done. And it is mostly practiced in many neonatal units in India as well as in Western countries. Now in this picture, you can see there is an immediate skin to skin contact given after birth. So baby is just delivered and then baby is put on the mother's chest, which can be easily practiced in a healthy term or even healthy preterm low birth weight babies. Here you have a preterm baby who is on CPAP and baby is being put in a kangaroo position, and we can continue giving CPAP, but we need to have enough expertise in the hospital to be able to do this, but it is possible and it has lots and lots of advantages, and it is being practiced commonly in various neonatal units. Here you can see the baby is on ventilator and comfortably lying in kangaroo position on mother's chest, and mother is nicely knitting some sweater and she is so happy, baby is comfortable. Again, you can see here a mother is giving kangaroo mother care, baby is on ventilator, and there is a NG tube feeding which is also being slowly given by the mother. She's giving express breast milk via the nasogastric tube. Even phototherapy can be continued while baby is in the KMC position. So there should be no reason for separation of baby and mother. And most of the nursing and medical care can be performed in kangaroo mother care position, like suctioning, taking blood samples, tube feeding, inserting IV cannulas, changing diapers, extubating a baby, listening to the chest, auscultating the baby. Okay. So a lot of things can be performed. We just need an expertise and good team. And in this picture, you can see 26-weeker twins who are on a ventilator and they are being cared in a KMC position. So here, mother and father both are giving kangaroo mother care to the babies who are ventilated. This is possible in MNICU. Now let's have a look at the KMC and cognition. So kangaroo mother care is postulated to improve the brain function of the newborn baby, and there is an increasing evidence towards its effect. So what are the various possible mechanisms? So there are three mechanisms. One mechanism is a sensory mechanism, which includes sleep, touch, smell, stress, and pain. Second is due to the effect of breast milk production and its effect. And the third is because of it is more psychological effect, like parental mood, activity, and depression. So how does these sleep, touch, smell, stress, pain, how does they affect? So all of these are sensations basically, and they have an effect on the formation of the neuronal connections in the baby. Disordered sensations in the newborn baby will lead to the poor neurological connections and decreased sensitivity. And kangaroo care will modify all of the above parameters, and thus it can have effect on the neuronal plasticity. Second effect is due to the breast milk production and effect. So multiple studies have shown improvement in the amount of breast milk which is produced, duration of exclusive breastfeeding, early establishment of breastfeeding, and duration of breastfeeding itself. So, and good breastfeeding practices have association with the better IQ scores. And psychological effect are So KMC will improve the parental involvement in the care. It reduces the incidence of postpartum depression in mother, improves the caregiving practices, and more stimulation of the newborn baby via talk, singing, movement, etc. will eventually lead to the better neurodevelopment in the newborn babies on long term. Now there is a effect of kangaroo mother care on the sleep organization. So when the baby is in the KMC position, it increases the quantity of the quiet sleep that baby can take. The pattern of the sleep can be non-chaotic. It promotes the normal sleep cycling, which is actually interrupted when the baby is in the incubator. And baby will not wake up frequently from the deep sleep, so less sleep arousals. And it also promotes the heart rate and respiratory rate variations according to the sleep cycle. So generally the preterm sleep cycle will require 60 minutes continuous to complete, and within the 5 minutes of onset of KMC, this cycle begins. And if we continue giving KMC for more than 60 minutes at one time, then it helps significantly with the neuronal development of the newborn baby. So formation of neuronal synapses and the growth and sleep cycling, there is a connection between the two. And the premise in the incubator demonstrate non-cycled sleep pattern throughout the hospitalization. And result of the delay in the sleep cycling will affect post-discharge sleep for up to 2 years. So basically those babies who receive KMC, they will be having a better sleep cycle, and that will eventually lead to the better neurodevelopmental outcome. So from South Africa, there's a professor called Professor Attis Mellon, and he gave this beautiful lines. He said, in affluence, those who are affording, KMC is a valuable addition to the infant care. In the financial constraints, it is a precious gift. And in poverty, it may be the only means of survival. And as a doctor and as well as a nursing team, we are actually the promoters of KMC. We can train our patients and mothers to give prolonged continuous KMC to their preterm low birth weight babies, and we can provide them those benefits of KMC. We can become the KMC champions and promote this practice in our own setup, and that will significantly affect the various outcomes in the form of reduced mortality, reduced morbidity, better neurodevelopmental outcome, better growth, better cognition, good attachment, decreased infection, decreased apnea, and many more advantages to the baby as well as advantages to the mother in the form of reduced depression and psychosis, postpartum depression in mother. So the take-home message of today's lecture is KMC saves lives, and the flow of evidences towards better neurodevelopmental outcome, and it is a very, very important and essential component of the better care of the newborn and preterm babies in the neonatal units. Implementation will need understanding of local barriers. There may be various local barriers, and there can be few favorable factors, and we as a medical and paramedical team need to understand those barriers and favorable factors, and we can try and remove the barriers, and we can make a use of those favorable factors and promote more and more kangaroo mother care. Thank you very much for listening this lecture patiently. If you have any questions, you can post them on the Telegram group that has been created for you, and we'll be very happy to answer your questions. Thank you.
Good morning, friends. Myself, Dr. Dipen Patel. I am professor in neonatology at Pramukhswami Medical College, Karamsad, Gujarat. Today we will learn about pain management in neonates. We all know that because we all work in NICU, neonate gets multiple exposures to painful procedures during the entire hospital stay, even if when they are stable. Neonates do perceive pain, but we also should remember that pain is much more intense when neonates are cared in NICU. There are known benefits of controlling pain in neonates, which improves physiological, behavioral, and hormonal outcomes. Despite there are well-known facts of benefits of controlling pain in neonates, implementation of pain controlling measures is not optimum, and in many centers it is not in existence. What we are going to learn in this lecture? We will learn brief details about pain, stress and discomfort, few definitions about pain, procedure, common examples of painful procedure we will see. What is the importance of controlling pain? What are the benefits do we get by controlling or reducing pain in newborns? How should we assess pain in neonates and how to manage pain? If you look at the history, in the 20th century, most of the NICUs uniformly denied or disregarded the occurrence of neonatal pain. So in that period, doctors and nurses, they did not think that the neonates do perceive pain similar to adults and older children. And because of this, and also neonates cannot express their pain strongly, so that the infant surgery was conducted routinely with minimum or no anesthesia until late 1980s. Can you imagine this? Robust responses to painful stimuli were dismissed as physiological or behavioral reflexes, and people did not thought that these are because of the pain. Newborns were considered as less evolved human beings. So because of this and because of that effect, still we are not optimum in implementing pain control measures. What does it lead to if we do not control pain? It has long and short-term complications like altered pain response. Children will have attention deficit disorders when they grow. They have impaired visual perceptual ability and also impaired visual motor integration. So these are neurocognitive problems also. If you think that as baby grow, what would have happened to the brain? Frequency of exposure to neural pain related stress have been correlated with impairment in cognitive development. Means the more amount of the time the newborn has experienced pain, there are higher chances of more cognitive impairment. There would be altered neurocognitive processing. Even the cortical thickness of the brain gets reduced because of the frequent exposure to pain in early life. It also dysregulates the hypothalamic, pituitary and adrenal axis. So this will lead to hormonal imbalance and multiple disorder later in life. What more? So these are some of the examples. What could happen if neonate experiences pain which is not controlled? See, infants of diabetic mother, you all know they are at risk of hypoglycemia. So what we do is we monitor them frequently by heel prick. And these newborns exhibit more intense painful response during later venipuncture compared with normal infants. So they show more facial grimacing and crying as compared to the infants who are not born from diabetic mothers and who are normal. So when the normal infants are sampled, like for thyroid function test or bilirubin, they will not exhibit so much pain as compared to the infants who are born from the diabetic mothers. Infants who are exposed to circumcision after birth, they experience great pain when they come for vaccine visit, and when we give immunization, they have intense experience of the pain. Even sometimes you would have gone to the labor room and you have attended the delivery. The pediatrician or the nursing staff, they do gastric suctioning. And remember, this suctioning is also associated with long-term complications like irritable bowel syndrome during the adolescent or adulthood. The adolescents who born preterm, they displayed higher somatic pain sensitivity than the adolescents who were born at term. In post-operative infants, those who received greater amounts of pain had poorer outcome as compared to the newborns who got good anesthesia and analgesia, and that lead to reduced levels of norepinephrine, epinephrine, glucagon, aldosterone, and cortisol. It reduced post-operative morbidity like sepsis, metabolic acidosis, disseminated intravascular coagulation, and also reduced mortality rate. So you can imagine how many are the benefits of controlling pain in post-operative period. So remember, and we should always take care that the newborn who have come from surgery and we are taking care of these newborns, first 3 to 4 days are very optimum in controlling pain. So these are certain definitions to understand this lecture better. What do you mean by procedure? So it is a sporadic medical, nursing or surgical. It may be diagnostic or a therapeutic activity which is performed on the child. Like infant feeding tube insertion from the nose or mouth is a procedure. Changing diaper can also be considered as a procedure. Even taking a temperature is also a procedure. Doing echocardiography, which is a diagnostic modality, is also a procedure. What do you understand by pain? You all know that it is an aversive sensory and emotional experience which is typically caused by or maybe resembling that caused by actual or potential tissue injury. So it can be physical, it can be emotional, understand? The fright is also a kind of pain. Remember, pain is a subjective experience and it depends or varies based on the degrees of biological, psychological and social factors. The procedure can be stressful or painful. Stress or unpleasant experience denotes disturbed equilibrium between the neonate and its environment, like changing diaper. That may be unpleasant experience to the newborn. Taking a temperature may be an unpleasant experience. Noise, frequent handling are these some of the examples of unpleasant experience which may lead to stress. And stress or unpleasant experience can be considered as mild form of pain. Remember that while managing newborns in our routine care. This management creates discomfort, stress, or pain, depending on the severity of the stimulus. So, which are these routine care or the managements which lead to pain? So, there are many you can see here. There are many, and this is not the exhaustive list. Like examining the newborn, even can be stressful. Even retinopathy or premature examination, you know that it is also very much stressful to the newborn. Doing diaper change, heel prick, a common procedure which is done to check blood sugar. Suctioning, endotracheal tube suctioning is a painful procedure. Phlebotomy to send blood samples. Peripheral intravenous line placement. Even removing the IV line is also painful when, because you know that the vein is inflamed, and when we remove the catheter from the vein, it is very much painful. Even noise and light are the environmental stimuli which creates discomfort or stress in the newborn. Surgical procedures creates maximum pain, but not only the surgery, but post-surgical period is also very painful for the newborns. As I already told you, first 3 to 4 days of surgery or post-operative time is very crucial for managing pain, which will improve the outcome. Changing the dressing itself after surgery, removing the adhesive tape, like we attach the temperature probe on the abdomen, and when we try to remove this adhesive tape, it is painful. Inserting nasogastric or orogastric tube, even removing this tube also very much discomforting to the newborn. Other procedures like umbilical catheterization, intubation, extubation, they are all associated with moderate or severe kind of pain. We did one study in which we observed more than 13,000 procedures, and we calculated that 44.1 procedure per patient per day occurred during that observation period. You can understand more than 40 procedures in terms of including examination, diaper change, taking temperature, everything, in which more than 2/3 were stressful and very less were mildly and moderately painful. But still, you can imagine that these newborns get constant stress during their NICU stay. So that's why some of the procedures or some of the pain preventing techniques may reduce this constant stress, like facilitated tugging, swaddling, etc. One of the common findings we got in our study is most moderately painful procedures were not adequately managed to control pain. Now, before going for pain assessment and controlling pain, you all must be aware what are the signs and symptoms of pain in newborns or infants. You can divide this in two categories, like physiological signs and symptoms and behavioral signs and symptoms. So if you think physiological changes, that means change in heart rate, like tachycardia, increased respiratory rate. It also increases the blood pressure, and the tone would also increase. Baby will have desaturation. Baby may have sweating. There can be flushing and also pallor. So during the experience of pain, you would have experienced that baby becomes pink suddenly. Or sometimes we have observed that baby also becomes pale. So these are signs of experiencing pain. So we should find out what would be the cause for this. Now, behavioral changes. Baby changes the facial expression based on experience of pain, like grimacing. There would be nasal flaring. There would be furrowing of the brow. There can be deepening of the nasolabial groove, curving of the tongue, and quivering of the chin. They are all facial expressions of perceiving pain. Babies may also clench their fingers. They may thrash their limbs. There would be twisting movement of the body. There can be arcing also. Babies may bang their head. There can be poor feeding. Baby will not get sleep properly. Even because of the experienced pain, they would not like to move their limbs and they feel that it is a pseudo paralysis. So, considering this all, can you imagine that the newborn has signs that we can examine that they are perceiving pain? So, based on these changes, we can objectively score the severity of the pain. So, the question is, can we measure severity of pain in units? Yes. But remember, because these are the behavioral and physiological changes which are difficult to measure quantitatively. That's why, though assessing pain in newborn is difficult to teach also, they might be time and labor intensive. It might often be open to subjective interpretation, and it might be a source of conflict in NICU care. We also have limitations in our NICU because they are overcrowded. Excessive workload in NICU does not allow us to assess pain accurately. But remember, adopting an objective pain assessment method greatly enhances the quality of pain management in NICUs. So, what is the importance of assessing pain? It helps us know the severity of pain newborn is experiencing. And we are so sensitized to this experience of pain, it will help us assess or estimate the modality of pain control measure to be given to the newborn. So it helps us to determine therapy which can be given to the newborn. Even it will help us to assess the effectiveness of that modality, like giving oral sucrose to heel prick, how much effective it is, how much it controls the pain. Even these methods help us to compare the effectiveness of each other, like oral sucrose versus skin to skin care in controlling pain because of the venipuncture, which is more effective. So using these methods are helpful not only to determine that they are experiencing pain, but also in research studies. So till now, because more and more people, as I told you, in the 20th century, they were not aware. But as the evidence increased, more and more number of methods are now available to assess the pain in newborns. Some of these are PIPP. This is premature infant pain profile. Second one is NIPS, that is neonatal infant pain score. Third one is NFCS, neonatal facial coding system. Then comes NPAS, neonatal pain agitation and sedation scale. CRIES score, it includes cry, requires oxygen, increased vital signs, expression, sleepiness in its consideration. Other one is comfort scale, Dubilier scale, behavioral infant pain profile. So these are the all commonly used scales in the neonatal ICUs, but each score has its own characteristics, so that they need to be particularly used in certain circumstances. For example, PIPP score which we commonly use at our NICU, can be used for procedural or post-operative pain which is mild or minor. Similarly, cry score can be used in post-operative period. NPAS score, which also includes sedation in its scoring system. So that's why it is used as a post-operative or a procedural or to assess the pain in ventilated newborns. So each has its own characteristics which may not be used interchangeably for different scenarios. So you should adopt for particular procedure which score to be used, for particular condition which score you should use. But predominantly you can see PIPP score usually includes most of the components, and that's why we prefer or we to judge the pain. PIPP score is commonly used in our NICU. So what is PIPP? Premature infant pain profile. Remember, though the name tells about premature because it was initially created for premature newborns, but now it is also validated for term newborns also. So the name is actually misnomer, but you should not worry that it is only for premature newborn. It is also for term newborn, which includes these 7 components. One is gestational age, second one is behavioral state, third one heart rate, fourth is pulse oximetry, brow bulge, eye squeeze, and the last one is nasolabial furrow. So these are all components are scored 0, 1, 2, 3. And based on that, we sum up this score and calculate the total score. So before we go to the how we score PIPP, you should understand what this brow bulge is, what is the behavioral state, what is eye squeeze, and what is nasolabial furrow. Because these are the terms which might complicate our assessment. Heart rate and pulse oximetry looks straightforward. Gestational age is also straightforward. So we will learn about this thing in the next slide. So these are about facial expressions. You can see here brows. They are lowered here and drawn together. So these are the eyebrows. So it is a sign for eyebrow. Second one is forehead bulge between the brows. They are vertical furrows. You can see this. Eyes tightly closed. This is also one of the examination finding for assessing the score. This is a nasolabial fold, which is a vertical. You can see just side of the nose and the angle of the mouth. It is a nasolabial fold. You can see it is very deepened. Second is nose broadened or bulging, nasal flaring. You can see mouth open and squarish. You can see the cheeks which are raised. So these are all the expressions which we use in assessing the pain assessment score in newborns. So this is the chart by which when we give the entries, we put the entries, it will give a total score. You can see here what event like heel prick. You can write here. Now what are the indicators that we should assess? Now remember, we should observe the infant for 15 seconds. We should observe the baseline heart rate and oxygen saturation. We should not eat first. So we should write gestational age. You can see 30 weeks or 36 weeks or more is scored 0. But when baby is less than 28 weeks, we give score 3. Means more the premature newborn, the more the score we give. What about behavioral state? That denotes the level of activeness about the opening of the eye and what are the facial movements. Based on these, 0, 1, 2 and 3 score is given. Now Change in heart rate, you can see here, more the number of bits changes per minute. Suppose here 25 bits per minute or more increase, it is considered as a score 3. So more increase in heart rate, more will be the score. More the desaturation, more would be the score. You can see more amount of bro bulge will give more score. Maximum eye squeeze will give maximum score, and no eye squeeze will be given a 0 score. Nasolabial flow more deepened would give more score. So this is not a complicated score. It is easy to remember also. Now what we can do is we can make some kind of mobile application or maybe a internet application or a software or system in your hospital in which you can directly enter the findings which will directly give you the score. So this is the system app in our hospital which we use for PIPP and NIPS. So we can directly enter the details which will calculate the score and will give us the total assessment. What alternative we can do is we can make a printout of this score and we can write the name of the patient, date and time of doing the procedure, and by each and every steps of assessment like gestational age, you just tick on the score. And at the end, you do the total score. Now remember for PIPP, if score is 0 to 6, means we do not need to provide any action. But if score is 7 to 12, it means baby is experiencing mild or moderate pain, for which we need to give comfort measures like positioning, non-nutritive sucking or sucrose. These are the non-pharmacological measures. But when score is more than 12, means baby is experiencing either moderate or severe pain, so in which we need to provide pharmacological interventions. So in short, what kind of measures can we use to control pain in newborn? So you can see they are divided into two categories. One is non-pharmacological and second one is pharmacological measures. Remember, it is very easy for us to provide non-pharmacological measures, but it provides some kind of assessment or a help of treating doctor for deciding pharmacological interventions. You can see non-nutritive sucking, giving oral sucrose or oral glucose, giving breastfeeding, swaddling, providing facilitated tucking, and skin to skin care are very easy and may not need expertise or the help of the treating doctor. But providing topical anesthesia like amla cream, giving paracetamol, providing injection lignocaine, giving fentanyl, morphine or ketamine, these are the drugs which may require calculation and order from the treating doctor. This is a very simple slide which provides all the answers at a single view. It is called as tiered approach of controlling pain in newborns. If you see at the baseline, at the bottom of this chart, we should emphasize of preventing pain. We all know that most of the time it is unavoidable, like doing heel prick for RBS monitoring. But if we can avoid painful procedures, then it would definitely help controlling the pain. Some of the examples are using NIRS, using pulse oximeter, or using end-tidal carbon dioxide monitoring and transcutaneous bilirubin monitoring will reduce the invasive procedures. And thus, it will reduce the overall experience of pain in NICU. Mild to moderate degree of pain are provided in the tier 1. So these tier 1 procedures usually gets controlled with non-pharmacological measures like heel stick, removal of the adhesive tape, changing the dressing, treating the wound, venipuncture, even if you puncture the artery for blood gas, giving subcutaneous injection or intramuscular injection, peripheral IV cannulation or removal of the peripheral IV, central line placement, insertion of the gastric tube, catheterizing the bladder, extubation, doing lumbar puncture, inserting the peripheral arterial line or PICC line, circumcision and chest tube insertion can be considered as a tier 1 approach. But practically you can see some of the procedures in these like circumcision, chest tube insertion might be more moderately or severely painful, in which only non-pharmacological measures would not work. So they should be combined with the more analgesic drugs or the injectable medications like nerve block in cases of circumcision. Topical anesthetic like lignocaine and pranlocaine cream or gel can be used in controlling pain with procedures like venipuncture, arterial puncture, intramuscular injection, cannulation. Even in circumcision also they can be used. So they can be considered as a tier 1 procedures. Tier 3 procedures like heel stick, when baby needs frequent heel stick monitoring. So only a short time giving oral sucrose may not help. So that's why this baby may require constant control of pain. So in this condition, we can use paracetamol. Local anesthetics means giving injectable lignocaine around the procedure area like lumbar puncture or peripheral arterial line insertion or circumcision, providing nerve block or chest tube insertion. These are tier 4 procedures in which local anesthetics will help controlling the pain. And at last, when pain is about to be severe in surgical procedures, wound treatment, lumbar puncture, intubation, chest tube insertion, as already I discussed, they are required to be combined, and in which deep sedation or anesthesia is required. Now, few facts about non-pharmacological therapies. I will not go in detail about the pharmacological interventions, but because you are being nurses, you can easily provide these in timely manner. So I will provide more information about this. So one is oral sucrose or glucose. Remember, sometimes we get confused from glucose and dextrose because at home we use sugar, that is sucrose. But in our hospital settings, we use 25% dextrose. That is actually glucose itself. So glucose and dextrose are same. So you should not confuse between glucose and dextrose. Remember, glucose or sucrose both are similarly effective. So whichever is available to your hospital, you can use it. And you know that 25% dextrose is easily available in most of the centers. You can use it very optimally if you do not have availability of sucrose. So which is available in the strength of 24%. More the preterm newborn, you can use less the amount of sucrose, maybe 20%. More the term newborn, we can use more amount of the glucose, that is 30%. Remember, glucose and sucrose have ideal safety profile and they have limited side effects. So we should not be hesitant using these when we consider them as a pain control measurement. Remember, when we give these oral sucrose or glucose in multiple doses, both before and after the painful procedure like Hin prick or Hill lancing, it is more effective than a single dose. So don't worry, you can give more dose also. But remember that this is not effective after 3 months of age. The best modality, which is easily available and more physiologic, is providing breastfeeding directly or giving express breast milk if his mother is not available or mother is sick. You all know that breastfeeding is developmentally superior to oral sucrose. And in many of the procedures, it has been found that it is almost equivalent to giving oral sucrose or glucose. So breastfeeding can be used for controlling pain during heel prick or venipuncture. But remember, giving only express breast milk might not provide that much pain relief as compared to breastfeeding. But remember, it is better to give something than nothing. So express breast milk gives some of the pain control with this procedure. So if you have available express breast milk, you can use it. Non-natatory sucking. When infants are offered pacifiers to control pain, studies have shown that it reduces the variability or increase in heart rate and decreases the episodes of crying. That means non-natatory sucking helps in controlling pain. So alone NNS is less effective than oral sucrose, but some of the times we can use these pacifiers dipped in sucrose and they would be more effective than using alone. We all perform swaddling in our NICU. We have already learned how to wrap the baby in the basic newborn care programs. So wrapping the baby is called as swaddling. Remember that it is more effective than no intervention. So as I have already told earlier, if you swaddle the newborn during the hospital stay, it will reduce the stress or discomfort. So it can be used as a routine care to reduce the stress. Swaddling and facilitated tucking are alone less effective, remember, than the oral sucrose. But when they are combined with oral sucrose, then they become more effective. What do you mean by facilitated tucking? It is a kind of nesting in which we keep the baby in flex position. So when we keep the baby in flex position, it gives comfort to the baby. It reduces the levels of active sleep, reduces the motor activity, and reduces the behavioral stress. Means providing this comfort with this technique will help controlling the stress to a certain extent. So if you give it with oral sucrose, it will be more helpful. You can see here, mother can also provide or comfort the baby with this technique. So in which we can hold the baby in a flex position and contain it. So that will help reduce the experience of pain. Skin to skin care. When we ask question to these PG students, what are the advantages of providing kangaroo mother care? They often forget to give answer that it also relieves pain or it also controls pain. So remember that providing skin to skin care soothes the baby. It stimulates the ventral, tactile and proprioceptive system and thus reduces neural pain responses. This procedure or this technique can be used for invasive processes like heel stick or venipuncture as well. So it may be used in combination with oral sucrose also. That will provide more effectiveness. Now, because of multiple non-pharmacological measures are available, multiple pharmacological interventions are available, we might get confused which to use and which not to use. So similar to this, you can also tag a poster in your area in which you can easily decide which procedure is best suitable for particular infant, because you all know that each infant is different. One is preterm, one is ventilated, one is stable in KMC ward and given KMC. One is mother is sick and not available with the newborn. So these are various circumstances in which the decision would vary. So providing this kind of poster in your area will help decide what kind of procedure you can use. Like here we have written IV line, you can use oral sucrose or you can use express base milk. For random blood sugar, for doing heel prick, you can use sucrose or KS feed or KMC or breastfeeding. So whichever is available to you, you can use immediately. You can use these in combination also, remember. As I have already told, using in combination, it provides more effect. Even for inserting the nasogastric or orogastric tube, we can use oral sucrose or KS feed of mother's milk, which will relieve the pain. Now, what dose we should use this? If we use express breast milk, we should give it 1 to 2 ml orally 2 minutes prior to the procedure. For oral sucrose or glucose, we use 0.5 to 1 ml orally 1 to 2 minutes prior, or we can also use during the procedure. But remember, for preterm infants, we should use less dose like 0.5 ml, and in term infants, we can use 1 ml dose. For kangaroo mother care, if you want to use it as a pain control intervention, we can start KMC first, and after 15 minutes of KMC, we can do the procedure like heel lancing. Similar to KMC, breastfeeding also. So when baby has started breastfeeding, after 5 or 10 minutes, we can do the procedure, because it takes some time to get endorphins released in the blood, and that will comfort the baby. So in summary, we should all remember that neonates experience pain in a similar fashion to older children and adults. And remember, they remember also painful experience, but not in a direct way, but in a different way. Each healthcare facility that treats neonates must establish a neonatal pain control program. We should routinely start assessing the newborns for pain, like 4 hourly or 6 hourly, or maybe more frequently in newborns who are sick and cared in NICU or on ventilators. Reduction of the number of painful procedures and episodes of patient handling will improve the outcome. And we should not forget to use the non-pharmacological and pharmacological procedures to control the pain, and we use them optimally. Thank you.